Good morning, good afternoon, or good evening to all of you joining from around the world. I'm Michelle Heisler and serve as Medical Director at Physicians for Human Rights. Central to my role as Medical Director are the skills, insights, expertise that I have gained in my work as a practicing physician, as a clinician. I'm excited to welcome you to this discussion to celebrate an early Human Rights Day that is on that very topic, clinicians as human rights defenders. Thank you for being here. Today, we've convened a remarkable group of clinicians. Each of them is working in multiple ways to promote and defend human rights, medical ethics, social and reproductive justice. They are going to guide us in a discussion on three urgent questions. How can clinicians best act as human rights defenders? How can we ensure we do no harm when our patients' best interests conflict with what the law is demanding we do? And how can clinicians deploy their unique expertise and voices in the face of unjust policies that violate human rights and harm health? Throughout history, health professionals have faced these questions, but they've taken on a new urgency in light of emerging and growing threats to human rights and the health of many in the United States and many parts of the world. Today, our speakers will help to unpack how health professionals can leverage their skills, expertise, platforms to rigorously document, call attention to, and advance accountability for human rights violations that harm health. Our speakers will highlight how clinicians are navigating professional ethical challenges in the course of their work, notably dual loyalty challenges, where state laws conflict with our duties to our patients. And the panelists will highlight how clinicians can act to defend human rights in response to really three critical threats we're now facing. The first is the overturn of Roe versus Wade and affronts to reproductive health and rights in the US. The second is the misuse of public health policy to undermine the legal right to seek asylum. And the third are the mounting threats and attacks against health professionals. We are so lucky journalist Rachana Pradhan has agreed to moderate this discussion. Rachana is a renowned correspondent with Kaiser Health News. She writes about a broad array of national health policy decisions and their effect on individuals and communities, especially communities that already face marginalization and discrimination. Rachana has been at the forefront of covering public health and human rights, from the COVID pandemic to the Dobbs decision and much more. We are all fortunate that journalists like Rachana are shining a light on these crucial issues. On our panel are four clinicians who each embody the guiding ethos of Physicians for Human Rights. They go beyond the bedside, beyond the clinic, to protect and defend the human rights of their patients and their communities. I hope that you, as fellow health professionals and allies, will come away from today's conversation with new energy, inspiration, and ideas on ways we can all work together to defend and promote human rights. Rachana, over to you to introduce our panelists. And thank you again, Rachana, for sharing your time and your expertise with PHR.
Thank you so much for that very effusive and kind introduction. So I'm just going to kick it off here by introducing our esteemed panel, and then kick off with some questions. But before I get started, I also want to make sure that I say that we also want to hear from the audience. So please be sure to submit your questions for Q&A that we will turn to later on during this session. So now I'll introduce our panel. So first up is Dr. Kristen Brandy. who is a board-certified OBGYN and a board-certified subspecialist in complex family planning. Dr. Brandy is currently the board chair of Physicians for Reproductive Health and is an abortion provider in New Jersey. Thank you, Dr. Brandy, for joining us. Next up, we have Dr. Monica Peak, who is the Ellen H. Block Professor of Health Justice in the Department of Medicine at the University of Chicago School of Medicine. Your guys' titles are just so impressive that I feel like I'm going to get tripped up on everything. So thank you, Dr. Peak, for joining us. Next up is Dr. Barbara Robles Ramamurthy. She is a triple boarded adult, child, and forensic psychiatrist and an assistant professor of psychiatry and behavioral sciences at the University of Texas Health Science Center at San Antonio. Thank you, Dr. Robles Ramamurthy, for joining us. And finally, last but not least, we have Dr. Matthew Winia, who is a professor of medicine at the University of Colorado Anschutz Medical Campus. And he also has a board certification in in internal medicine and infectious diseases. So thank you all for joining us. I'm really excited about this discussion. And I just want to kick it off with a broad question for all four of you. It's December 2022. We have been through lots of upheaval in the United States and around the world over the last few years. And so I just want to ask, when you think about human rights, what does human rights mean to you at this point in time? I want to pick on Dr. Brandy. Why don't you start?
Sure, it sounds good. And thank you so much for having me. It's really lovely to be amongst a lot of interesting folks in this panel. I mean, I definitely think that human rights has taken a new form, particularly in the space of reproductive health rights and justice. That when I think of human rights, I feel like we're used to thinking about, making sure that people have, in the space of healthcare, equitable care that is centered on that individual person, making sure that care is not infringed upon based on, laws of a country or a state. And thinking about the Dobbs decision, it feels like human rights are being violated across our country right now. And unfortunately, we're at a place where there are 13 places where people do not have the human rights to be able to access safe reproductive health care. And so it's really a challenging time, and I'm really concerned about how this extends to other types of human rights violation across our country.
Dr. Peak.
Yeah, I'll go next. I think I would say that human rights are the ability of a person to have the absence of real or potential threats to their bodily, emotional, or mental integrity, and that of themselves or their family. And so for me, for example, I think about state-sanctioned murder or violence against Black men. And that has had an impact on, people that I know and love in the community, the way that I navigate my way in the world. It hasn't had a direct impact on me, but it has affected my ability to feel free in this country. And I have a son that's a teenager, he's about to turn 14. And so I don't feel like Black people in this country are truly free, because we aren't able to move freely around without the same sort of opportunities and lack of harms and risks that others are in this country who are white. And so I think that human rights, for me, has a very expansive definition about infringements that are real or potential to a community.
Dr. Robles Ramamurthy, please.
Yes, thank you. It's an honor to be with you all today, and thank you for those two definitions and helping us think about human rights. I've been reflecting a lot about this definition over the past few days as we are preparing for this panel, and as somebody who just recently fully embraced that I belong in different spaces and rooms and conversations, I want to make it clear for everybody in this room that you don't have to have a formal definition or understanding of human rights. For me, it started when I was a kid, a teenager, and really learning to trust yourself that if you're a human rights defender, it's already in you. That understanding, that knowledge, that awareness of what human rights mean, that's already inside you. So for me, it really has come to trusting that inner knowledge, that instinct that I have had since I was a child of what is it that makes people feel safe in the world, that makes them feel that they are treated with dignity, that makes them feel that they can create a life that is worth living and that feels right for them. And so all of those things come to mind when I think about what human rights and defending those rights means.
Dr. Winia, how about you?
Yeah. Well, thank you for putting me last so that I could have time to think about this. So what immediately jumped to my mind when you asked the question, and by the way, for those listening, and if it's not obvious, we didn't know this was going to be the first question. so it's a nice, it is a provocative question in some ways. There are definitions, of course, of human rights. There are written down definitions of what human rights are. They're in things like the UN Charter for Human Rights, and the World Medical Association has a definition of human rights. And so when you asked the question, it really made me reflect on the fact that, this year we have seen a number of anniversary celebrations of the 75th anniversary of the Nuremberg Code. And we're recently past the 75th anniversary of the end of the Second World War. And there's a pretty good argument to be made that the notion of human rights has sort of a common morality, and understanding that everyone is supposed to have universally across the entire world, no matter your cultural background, that there are certain fundamental aspects of what it means to be a human being that should be respected no matter where you live, no matter who you are. Right. That idea that there is a common morality that encompasses all of humanity really got a boost coming out of World War II. It had existed prior, obviously, but it really got a boost coming out of World War II. And I guess, I don't know if you were intending to segue into physicians for human rights, but the other thing that happened coming out of World War II was the recognition that doctors, nurses, health professionals have a particular role to play in defending the rights of human beings everywhere in the world. And there are a number of reasons for that, which we can probably talk about as we move forward. But that was what you triggered me to think about when you said, what does human rights mean? I think of human rights as being a common morality. It's a framework that we use to think about what every human being, no matter where they are, deserve. This level of sort of respect for fundamental rights. And it made me think about the origins of that conceptualization and the ways in which the medical community has a particular role to play.
Well, that was great. I really appreciate your guys' insightful responses. And I think it does actually what you just said, Dr. Winia. I'm going to go in reverse order this time. So I'm giving you a heads up. So I'm going to ask you to go first to segue into my next question, which is, I do think when we, I think in the general public, let's say, when you think about human rights violations or you see them being committed, sometimes people will focus, of course, on the victims. Other times you'll focus on the maybe institutions or governments or other people that are committing those atrocities that are causing the suffering of people, but not always everyone in the middle, right, who has to sort of respond or have some other role in sort of reacting or preventing those kinds of things from happening. And so can you start with sharing actually how are medical professionals sort of have how are they uniquely equipped to defend and promote these things? And also, how has that changed recently? I mean, we've, even just thinking about some of the recent changes from the Supreme Court, and then also the pandemic, right, the last few years, and how that has altered life in America considerably. So I'm just wondering if you could start with that.
Yeah, just that little narrow question. I'll get started, and then I'll pass the baton to others. I would say, number one, when you start speaking of rights, that comes along with some form of obligation to protect and defend those rights. So when there's a right, there's also a corresponding obligation, and that obligation is sometimes on the part of society, on the part of governments, but sometimes it is on the part of all of us as individuals to help protect and defend the rights of everyone else, right? That's the sort of foundational understanding of democracy, is that we are all responsible for protecting each other and making sure that that our fundamental human rights are defended, which is why I said these ideals go beyond, they started before World War II, right? They're in our Declaration of Independence. They were not well instantiated for many, many years. They still are not perfectly instantiated in the US, right? We have plenty of work to do, but the ideals have been around for a long time. And the roles of physicians in this are unique because part of human rights is about defense of the least defended, right? The people who are most vulnerable, most marginalized, least likely to be able to defend their own rights. And so you start asking, who's in a position to defend the rights of the defenseless? And so this is how you end up with professional obligations for teachers. It's how you end up with professional obligations for engineers and lawyers and priests. And right, these are people who are in a moment or a position of being unable to defend their own rights to the fullest. People need to be able to step in and defend them. And doctors, nurses, we see people at their most defenseless. We see people who are in moments of tremendous vulnerability when they are unable to defend themselves sometimes. In the extreme, right, they are literally unconscious, so unable to defend themselves, and they rely on us as their protector in those moments. And I think that's true in, the case of people sitting in ICE detention. It's true of people in prison. It's true of people in hospitals who are extremely ill. It's true of, a woman seeking care for a pregnancy that may put her at risk or that is, endangering her in one way or another. They come to us for advice and guidance and help. And that puts us in a unique spot, where we are in possession of the skills and the knowledge and the expertise and the social standing, et cetera, to be able to defend people when they are in their moments of vulnerability.
Go ahead, Dr. Robles-Ramamursy, please.
Yeah, I really love that reminder of the privilege that we have as physicians to sit with people in vulnerable states and truly use our skills and capacities to support them in those situations. And I guess what comes to mind as you were asking that question, how are we well positioned or skilled to defend human rights? What comes to mind is, we still have a way to go to help clinicians really connect the dots when it comes to our medical clinical training and how that relates to healthcare being a human right, right? And our access to health promoting activities and environments. And we are still connecting those dots in our clinical training, our medical training. And so I think that we are very well positioned to sit with people and accompany them through those painful illnesses that they may be experiencing, those situations that they may be experiencing. But then this is where, Dr. Heisler mentioned that's what PHR, Physician for Human Rights, we have to go above and beyond that clinical bedside to really protect human rights. And that knowledge and awareness often comes to us through different mechanisms, whether it's lived experience, through a loved one, or our own illnesses, as experiences as patients, or even just working with the communities that we are trying to really support and walk with. I'm sitting outside of my juvenile detention center, which is my clinical site, and I'm thinking about that as I am answering these questions. And so I think we are well positioned. We are in a very privileged state to support people in those vulnerable situations, and we are required to go above and beyond to really promote and defend human rights.
So I would add, and it always gets harder the farther down the line you are, but I would add that what we have, the challenge that we have is to take the skills that we've been given as clinicians, as people who we all have some basic training in ethics. We may not be an official bioethicist, but we have all had some training in end of life care, in informed decision making, in palliative care, in challenging issues with families. So some sort of ethics. Some of us are clinician investigators. So the question is, how can we apply these skills that we have to the socio-political landscape in which we live, and find ourselves with so much inequity, so much harm, so many violations of human rights. So using the pandemic as an example, how do we use our voice, our ability to think about bioethical principles and how the vaccine should be distributed fairly? How do we think about disparities, as health disparities, as a moral failing of our country? And how do we do research that highlights that? That, it's not just say that I think this is the wrong thing, but here's the data showing that it is wrong, and that if we do it this way, that it could be better. How do I use my clinical skills to work at a juvenile detention center, or to do asylum cases, those cases, that have physicians that have evaluated the patient are so much more likely to be successful than those who haven't had a physician who's evaluated the cases. And so how do I take what I have already been trained in and apply that in a way that supports the goal of justice, of social justice and human rights? There's not a school of, there's public health school and there's medical school, but there's not human rights school. That doesn't exist. And so what we have to do is think about the framework of what we already know to be true just by our lived experience, and apply the skills that we already have to injustice and make that work. Everyone has a different skill set. And for me, both of my parents were first generation college graduates, and, came up through racial apartheid in this country. And so there was no question I was going to be part of a movement that had to do with social justice. And so, I don't know what I was going to be, an artist or, whatever, but it was going to be around social justice. And so the question is, how do we as physicians take our own natural skill set and apply that in a way that is meaningful?
Dr. Brandy?
Hard to follow all of those great ideas around this, but I think what I'm hearing as that common thread is like our positionality in this space, our particular privilege that we have as physicians. And while we have a unique set of skills to be able to provide clinical care, the other unique skill that we all carry is the ability to listen to patients, hear their stories, give them the humanity that they deserve in the provision of care. And I don't think that's any different, even though the world looks differently right now. But I think a lot of providers in the repro health space as well, and broadly, is that I think physicians are finding themselves in a new space where they are having to advocate for the care of their patients as a component of that person actually being able to get the care that they need. And that's something that we advocate, when we're in our hospital and our clinic settings. We're used to talking to the nurse manager or figuring out how we can provide care to people, but we're just using those skill sets on a broader scale. And I think particularly within the repro space that we're used to doing that. I'm really honored to be able to hear the stories of people getting reproductive health care that they may not share with others, that it's something that's really personal, it's really private. And I don't want to necessarily use the word vulnerable, but I think, we are honored to enter a sacred space with our patients. And it's something that, as physicians, another thing that we can add on to that level of skill set is sharing their voice, and not doing so in a way to, capitalize on their experience, but really in spaces where people are stigmatized for whatever reason. How can we as physicians speak out, share these stories? Because as much as people want to be neutral, our jobs are inherently political. The provision of care, especially now in the United States, is a political act. And if we don't advocate for our patients, and abortion providers have known this for a while, but I think a lot of other spaces we're seeing that more and more, that if we're not going to speak up and make sure our patients get care, then no one else is going to. And so I think we have that obligation to be able to do that.
I actually want to piggyback on that, because I've for what you were saying. I mean, how do you find the balance with, of course, physicians have to abide by laws that protect patient privacy, but these are very broad, intimate, personal, often difficult moments that people experience in their life. And so how do you figure out how to thread the needle, especially since you all are the ones who are caring for these people directly? Like, I just wonder how do you even begin to have that conversation with your patients? It's another curveball for you guys. Who wants to take it first?
Yeah, I'm going to say
I'm gonna
these
have
are
a
really
few,
challenging
so,
questions. I
yeah.
appreciate the challenge, though. It's not easy, and particularly when there are institutions that are trying to, interfere with our ability to practice medicine for whatever reason. I think the main thing that we really need to focus on is centering that patient. Even if we're in a space where we can't provide the care that we know is evidence-based, that we've, been trained in medical school for years and residency for years to be able to provide this care, there are still things we can do. It's not necessarily that we can't provide them any care, but we have to really navigate that space and center what the patient needs. And also really naming the fact that we are not agents of the state. We are not people that are perpetuating this harm. So what can we do within our systems to minimize as much harm as we can?
Can I come back to something Dr. Brandy said a second ago, which is that abortion providers have been doing this for a long time. And for a lot of the rest of us, we're having to figure out how to be allies now. Just to be very blunt, I think in many ways, the sort of rest of medicine has marginalized people who provide abortion services. And so we've been, in a sense, sort of complicit in the social milieu that has created what we're now having to deal with. And so many of us are now finding that, we didn't have to think about this a whole lot until last summer. And now all of a sudden, I'm in infectious diseases. I could be called to render an opinion in an urgent circumstance as to whether this person's, premature rupture of the membranes and early fever puts her at risk of death. And can I sign off on that? Because that's what's going to be necessary in order for her to get the care that she needs. Otherwise, we may just send her home because we're afraid that if we do the DNC on her today, she's not at death's door yet, and we may end up with some zealous local prosecutor coming after us. And so the risk that abortion providers have doctors, abortion, people, it's like this whole dynamic has been, there's abortion providers over here and there's the rest of us here. And that's been That's been for 50 years, maybe longer. So it's going to be hard, I think, for us to realize that we are actually all in this together right now. And you're seeing a lot of statements about this from medical professional bodies, which is great. But I think also we're grappling with what does it mean to be all in this together? Which doesn't exactly get at your question, but I feel like, I don't actually end up having that conversation with that patient because that's not part of my practice. But my practice does involve making decisions and providing advice and guidance that is important and has become now suddenly political.
Mm-hmm. Maybe, and I do want to get to some kind of specific areas, which we'll talk about the Dobbs decision, but also, but Dr. Robles Ramamurthy, I'm wondering if you could talk about that, because I do want to talk about Title 42, and I feel like that, that is an area where, it's a relatively new development just because of the pandemic. So.
Yeah, so going into Title 42, which was the invocation of public health law to really prevent people from being able to exert their human right to seek asylum in our country. That was particularly established or used in the southern border with Mexico, and really resulted in a lot of harm for people because they ended up having to stay in Mexico where they were really unprotected, right? Without any voice truly being seen, acknowledged, right? And really susceptible to violence there, at risk of violence, but also just the ongoing family separations and difficult decisions that all of these people had to make. And so, Rachana, did you have a particular question or focus that you want to go into that?
Well, I'm just wondering, and we can talk about sort of the way that the medical community organized or surrounding Title 42, but I just wonder if it's, given the population that you're, addressing, I mean, how do you begin to think about your advocacy work in light of, like, these are people who are experiencing extreme, harm? And I just don't know, I guess for the audience, it's, how do you begin to thread the needle between advocating for certain things while also, of course, protecting the vulnerabilities that of the people that you treat?
So clinically, these individuals, as you all may know, really will show up in the emergency room, right? And so my work clinically is in a juvenile detention center or a kids jail. But what our work has entailed has been in partnering with organizations that are on the ground here in San Antonio and South Texas, who are providing aid and relief and support and, healthcare and legal aid and all kinds of support to people who have been impacted by Title 42. And so I have amazing colleagues who spend evenings or weekends covering, a bus stop that sometimes sees asylum seekers coming through. They do health screenings and help them figure out, connect with resources that they might need. And so there's that kind of advocacy and partnership and collaboration that is ongoing, and people are tirelessly working on that. There's some of us who perhaps have forensic training and are doing more of the asylum evaluations, or even partnering with legal organizations, Raices, but also other organizations in South Texas who need letters, for example, to document trauma, to document a particular special need, to try to overcome that Title 42 barrier that individuals are experiencing. And so I think it's been extremely demoralizing. It's been really emotionally tolling for sure, but I also feel very hopeful and connected to the amazing individuals on the ground who really find ways to promote collectivity and I guess how I thread that needle when it comes to advocacy versus providing some form of clinical expertise or care is that I really have to remember that I'm a human being first, and remembering that if I was ever in that situation, or my loved one was in that situation, what kind of support would I want them to receive? And that really guides a lot of the work that I do.
That's really insightful. I do want to pivot a bit kind of to the Dobbs decision, sort of along this thread of this discussion. And Dr. Brandy, I'm wondering if we could start with you on this. We have seen ample coverage since late June about the position that physicians have been put into when they have been trying to provide care that their patients have sought, and how that may or may not conflict with the laws of their individual state. And so can you talk about what it is like? And you're in New Jersey, but I do wonder if that is something that still comes up in your line of work. And I'd like others to weigh on this as well. So feel free, to talk about how top of mind is it for you, like every day, that you have these competing interests now in multiple states in America?
Sure. Thanks for that question. And I think that's something kind of leading into the conversation we were just having about this idea around moral injury, that a lot of physicians right now are challenged with this idea of like, how do I do what is best for my patient when I'm in a system, when I'm in an institution that is not going to protect that patient, is not going to protect me as a provider. And even though I am in New Jersey, I do have to consider what the impacts are. For example, if I take care of someone from Texas or, Mississippi, how am I documenting that care that will then be used? Like, how am I communicating with that patient that could be used against both of us? It's been really heartbreaking, in part because it's also been a year where there's been a lot of great advances. For example, complex family planning has officially become a subspecialty within OBGYN. So science hasn't changed. The care hasn't changed as far as what is the evidence-based. It's more, how do you tell a patient that even though I have the skills and knowledge to take care of you, that I can't? And the family planning world is small, and I hear these stories from my friends and providers across the country. Both the challenge of how do you provide care that is potentially suboptimal, that is potentially against evidence-based, but also it's heartbreaking to think about how, because we are put in this position, that our patients no longer trust us. And that's also particularly heartbreaking to think about how we are in a space where we are having to make decisions that we don't agree with. And our patients are also engaging with us in a space that is guarded, where in past, they would just tell us whatever, when their last menstrual period was, when, what their thoughts are about their pregnancy, that we're playing this game of chicken that I want to help you and you want help. And I don't know if I can do that because of the space that, again, we're being placed as agents of the state where we're supposed to comply with these laws because we're good people and want to follow the laws. But we know they're not right. And we know that's something that, is harming our patients. I don't have a good answer about how to navigate it other than each person is trying to figure out their own level of risk, their own level of how they want to provide care and whether or not they can provide it in the space they're living in. How to document more carefully to make sure that we're protecting our patients as best we can. Yeah, it's just trying to figure out each day what you can do and centering our patients as best we can in this moment.
I'm going to read something now that Dr. Winnia, that you wrote recently in a piece for the New England Journal of Medicine about the Supreme Court's Dobbs decision. You wrote that professional civil disobedience may be what is required to repair the moral fabric of our country and the integrity of our profession, which have been so injudiciously ruptured by the Supreme Court. What is professional civil disobedience in the context of medicine? And when do you think it might be necessary to use?
So civil disobedience is probably familiar to everyone listening. The idea of civil disobedience, Mahatma Gandhi and Martin Luther King and Henry David Thoreau, right? The idea is open defiance of an unjust law and willing acceptance of punishments as a means of drawing attention in the hopes that you will change that law. I think there, just as a side note, I think there are many reasons why physicians are reluctant to embark on civil disobedience, and they are reasonable, rational, justified reasons, starting with the fact that, you know, there were quite a few doctors who disobeyed abortion laws in the more distant past, in the pre-Roe era. And at that time, the penalty for disobeying an abortion law was generally you would pay a fine. So that was, you know, probably a reasonable thing to expect people to do. Today, there are state laws that will put you in prison for the rest of your life, right? Life in prison, and automatic loss of your license. Even before the case, you know, goes to trial, you can have your license pulled. So the penalties for civil disobedience are extremely high. And on top of that, we have the fact of modern healthcare, which is no one does anything alone. So if you want to breach one of these laws in an open and defiant way, you would need your hospital or your clinic, or right, you would need a team of people to go along with you on this, because we don't do things, you know, you can't put a central line in without 3 people showing up. Plus it's in the EMR, and right, so there's people aware. So anyways, that gets me to the sort of next level up, which is civil disobedience has often been thought of as something that individual people choose to do. But in fact, civil disobedience is often pretty well organized. And occasionally civil disobedience is organized at the level of a socially sanctioned group, like a profession, right? Like a professional organization, a professional body. And when that happens, when civil disobedience is no longer at the level of, I as an individual cannot tolerate this law, I refuse to obey it, I'm doing so to call attention to it, right? Now you're talking about a type of civil disobedience which is potentially more likely to be effective, because having one person, you can deal with that. If you've got thousands and they are in a socially sanctioned group that, by the way, is charged with protecting the health and well-being of the community, and we are saying, look, in order to do what we are charged with doing by society, we're going to have to fight against this law. I think that takes on a different color. And so that's what I was arguing for in that piece, is to move up a level from thinking about civil disobedience at the level of individual doctors and thinking about it at the level of an entire profession. What would that look like? How would that actually work? And by the way, I think we also have to realize that doctors are being placed in an untenable situation where no matter what you do, you may end up in court. Because if you fail to provide the standard of care in some states, you could be charged with malpractice. Your site could be charged with an EMTALA violation, et cetera. And if you do what is required under the standard of care, you may end up under criminal sanction and with criminal charges against you. So doctors are, you know, between a rock and a hard place right now, where if you act in one way, it's malpractice. And if you act in another way, you may end up in court defending yourself against a criminal charge. And so we need to be ready to help defend those doctors, whatever choice they end up making in that impossible, you know, rock and a hard place situation. We as a professional community need to be thinking ahead. You know, we're already seeing lots of stories of people doing what, you know, under normal circumstances, we would say is malpractice. Because they think that if they do otherwise, they'll end up with criminal charges. And it's really only a matter of time before we start seeing those cases come up. And likewise, it's only a matter of time before we see a doctor who just chooses, you know, with their local professional community to do the right thing, and they end up in court because some zealous local prosecutor thinks they'd like to make an example of this person or this institution as a way of, you know, promoting their political career in their state. Sorry, that was a long
dovetail-
answer.
No, you're fine. Does anyone else want to weigh in before I take? I would just remind folks, if you have a question, please submit it in the Q&A box, because we'll be getting to those shortly. So let me just pause and see if anyone else wants to weigh in on my question about Dr. Wynya's piece.
I think it's brilliant. I think it harkens back to how we have been successful previously with social movements. But I also think that it's important for us to not be like ahistorical or contextual, in that the people that are most affected by this ruling are low-income women of color. And it is because of that, in large degree, that it's been able to be successful and to be let's say as largely invisible, because it hasn't been, but the immediate effects, right, have been largely invisible, because it passed quite a while ago. All things considered, we're in the winter time. It was this summer. And so again, the people who are the most marginalized are the ones who are attacked the most for human rights. It's not the ones who have the most social capital, the most resources, the most connections. And so we have to be willing to stand up for those whose society has already forgotten and has decided it doesn't matter as much. And the same thing with COVID. COVID hasn't gone anywhere. It's just become more ghettoized into populations that society doesn't care about anymore. The people, we've been vaccinated enough that we have reopened our communities, but there are still pockets who are highly unvaccinated in this country. There's whole countries that haven't been vaccinated at all. But in this country, we've decided that we're fine, because the important people have been vaccinated. So the sociopolitical landscape in which human rights violations take place is also important for us to consider, because it impacts how willing and how fast we're willing to address these issues, and whether or not we as a medical profession decide to stand up for women, which are largely going to be low-income women of color, and put things on the line. I think it's going to be, affected by the fact that a lot of the women are going to be women who don't look like us, that we're trying to defend.
And actually, Dr. Feig, on that note, I do want to raise racial disparities in medical care. Of course, you have led a lot of research in this area, and also on health equity. Could you talk about how has research helped you to address some of these very entrenched, disparities in our country, and also talk about any pushback that you've gotten and whether that has accelerated in recent years, just given the political environment and anti-institution, anti-science, anti-public health that's sort of taken over?
Yeah. So for me, when I make a long story, your own life story short, I went to public health school thinking that I wasn't going to be a researcher, that I was going to do, health policy, and I still do health policy research, but it didn't really ring a bell until I thought about people like Paul Farmer and others who had expertise in what they were doing, that no one was going to be interested in what I was talking about unless I knew what I was talking about, right? That's why I went into doing research into health disparities or health inequity, because that's when you have the most ability to advocate for injustice, when you're actually working on injustice and can talk about it. And so I actually was motivated by a desire to make change, and that's why I became interested in investigating these issues. So for me, they go hand in hand. And I would say that I am at an institution where I'm just extremely blessed to work with people who are really smart and really good, with data. And so we're able to publish really solid research in top journals. And so people can't say, well, that wasn't very good work, so I don't get, people may not like it, but no one can say that it wasn't solid science. And so I don't really care about anything that people have to say otherwise, and so I have been able to collaborate with great minds who can push an equity agenda because we have the facts about what racism and other structural inequities are doing for socially marginalized populations. You have to plan for equity, is what I always say. You have to plan, and you have to plan for equity. And if you don't do both of those things, we'll continue to have the outcomes that we have, which is an inequitable system that delivers inequitable care and have inequitable health outcomes. And that's just the truth of the world that we live in. And we have to address the inequities outside of healthcare as well. And so, that's I feel like people, oh, I might start crying, that the people who have come before us have worked so hard for justice and freedom, that the least that I can do as a clinician and as a scientist is to state the truth, and to state that loudly, and let the cards and chips fall where they may. It's the very least I can do is to work for justice as a physician. So.
Thank you for sharing that. I do want to turn to audience questions. We have a few here. One is about organizing, but in the context of unionization, labor unions. So could you offer your thoughts about physician or healthcare worker organizing as a means to support each other with regards to moral injury that you all talked about, and with regards to active civil disobedience?
I just want to, I'm not going to say much, I'll let others speak, but I just want to explicitly name how Dr. Peak just embodied and displayed that very explicitly for us, right? Opening up the spaces for people to share their emotions, because this work is not easy. It's exhausting. It's emotionally tolling for us. And I think that when we learn that you are going to cry because this work matters to you personally and in so many ways, and that is beautiful, right? And that you bringing that into the table, into the rooms where we are, that to me is part of this, the way that we address this moral injury that we're all experiencing. It is exhausting. And thank you, Dr. Peak, for bringing that in here. And I hope that we can do that more for each other, really learning to tolerate the feelings, because the only way for us to move forward is to accept that there's feelings there, learn to process them, and learn to navigate them to push us forward and not get us stuck.
Yeah, I'll endorse that as well. I think these are real issues. They're not like textbook hypothetical philosophizing. There are real people involved who are being harmed. And so, we earlier talked about Title 42 as an example, where, this was an extremely cynical use of public health emergency powers for purposes that had nothing to do with battling the pandemic. And to watch that happen as a public health professional is profoundly damaging. I traveled to the Rio Grande Valley a couple of years ago, early in that time frame, and it is just destroying to walk through, the tents where people are living in squalor, and because of a public health policy. And I totally put that in scare quotes, because this had nothing to do with public health, right? So I agree with both Monica's sentiment and the reflection on it as well. In terms of unionization, that is a means to an end. It is one mechanism. I think it has strengths and weaknesses. As you probably know, I worked at the American Medical Association for 18 years. The AMA is kind of a union in a sense, right? It's a group of people who've come together to advocate for themselves and the values that they care about. And it has, therefore, some of the same weaknesses and strengths, right? It's very easy for unions in particular, and the AMA as well, insofar as it is a quasi-union, to act in the self-interest of the members, and not so much in the interest of the values that those members ostensibly hold up. But it's also very possible, and we have examples of this. There's a residents union in Boston that did really terrific work around the sale, essentially, of Boston City Hospital years ago, to ensure that the patient population would continue to be cared for after the sale/merger. And so there are unions that look out for core values that matter to society and the vulnerable and not vulnerable. But I'm reflecting on Dr. Brandy's comment earlier about vulnerability, which reminds me of the comments about voice. These are communities who have voices. They're just not always listened to. And, so I'm sometimes uncertain what the words are that make the most sense for the context, but there are times where unions of health professionals have worked to preserve the rights and dignity and well-being of the communities they serve. And there are times when those unions have acted purely in self-interest to get higher pay and better benefits. And by the way, that's not necessarily a bad thing. We're talking now about moral injury, right? Like our self-interest is sometimes in the interest of our patients and communities. We have to take care of ourselves. So it's complicated.
I want to end on with one last question for you all. The question is, in my experience, there are many clinicians who want to advocate for human rights, but they are in a work environment that does not allow them to engage. How do we activate medical and/or healthcare institutions?
I think every clinician can engage in some way in advocating for human rights. They can volunteer to do asylum cases. And so that's on their own time. All patients are advocating, all clinicians advocate for their patients, in their own ways. But I think there are lots of ways that people can do that. And I'll just list that one, is to volunteer to do asylum cases. And I'll turn it over to others.
I think I'll add, and first I just wanted to name the fact, thank you, Dr. Peak, for bringing in ancestors and bringing in those that have come before us. And tying into the conversation we're just having about unions, that structures are built because of people, and we make those structures, and we have the ability to change those structures. And we have to continue to remember the intersectionality that exists within these issues, that we are fighting for human rights on so many different levels. Like, my ability to provide reproductive health care is also impacted by someone's immigration status or incarceral status, race, ethnicity, disability status. Absolutely. So we are all together in this, and whatever we can do to help organize within all of our particular interests as well as a broader interest. I think that's the only way that we're going to fix structures and systems that are perpetuating harm.
Well, thank you so much for all of your thoughts to all these questions. Hopefully not too many curveballs, but I had to throw in a few. But I'm going to turn it back to Dr. Heisler now to wrap up.
Great. Well, thank you so much to our moderator, to you clinicians. who powerfully touched on challenges that clinicians are facing. And you touched on just a few areas, but key areas: defending the rights of asylum seekers, of minoritized groups who face the most human rights violations and often the worst health, of pregnant people. I hope all of you, I'm now turning to the audience, I hope all of you will reflect on the health and human rights issues that you most deeply care about, that you might be able to make a difference in. As Dr. Robles noted, you can use your clinical skills to rigorously document physical and psychological harms from human rights violations for asylum cases, litigation, improved policies, heightened public awareness. Again, under international law, abortion bans are torture and cruel, inhuman, and degrading treatment. We may be at a point where we're documenting those psychological and physical harms for litigation, as has happened in Peru, Colombia, the Philippines. So again, there are many ways that we can directly use our clinical skills. Police violence, we're using our clinical skills to document that police violence often truly meets the definition of torture against, deaths in custody, against largely people of color. As Dr. Brandy also emphasized, you are clinicians who are first respondents. You're at the front lines of caring for people whose rights are being violated, and you can amplify their voices. You can amplify their stories. Again, we're in such a privileged position. I loved what Dr. Robles said, or Dr. Brandy, I can't remember who now, everything was so good, that we have such a privilege to share sacred space with people, and we have to honor that, and we have to share their stories. As Dr. Peak described, and I'm in that camp, like Dr. Peak and some of the rest of you, I'm a clinician investigator. As clinician investigators, we can generate indisputable data, evidence of harms, to get the truth out and inform solutions. So again, that critical role, I think many in the audience now are in fact also clinician investigators. And as Dr. Winnie has said, all of us can push our professional associations, and many of them are doing it. It's remarkable, the positions, the American Medical Association, ACOG, American Association of Family Practice, the American Nurses Association. Really, it's kind of remarkable how much they've stepped up in the way that Dr. Winia has urged to really support their members, to support us, so we can speak the truth, we can fight for justice, we can center our patients' rights, and we can fight for the health and human rights of people everywhere. So thank you all, and so much that can be done. And again, I hope the audience will also keep contributing ideas and ways that we can act as clinicians. Thanks so much.